So this is the respiratory tract medication presentation. And honestly, this presentation is probably the least dense of the presentations moving forward. Respiratory tract medications, I believe this one has 28 slides, and is a lot less overwhelming. I don't mean to like put that on you, but it is a lot less overwhelming than the presentations that are going to follow that are upwards of like 40 slides because of how many medications are included and what you need to know about the medications and how they affect the body and how the body affects them and all of that good stuff. So we will just jump right into respiratory tract medications. So every medication that we discuss throughout this presentation, it's either going to do one of three things. So it's either going to open up a narrowed airway, or it's going to calm down an inflammation or an immune overreaction, or it's going to manage secretions and coughs. So it widens, it calms, and it manages. That's basically how this whole unit works in one sentence. So these are your learning outcomes, and you can, go through and read those on your own and understand what this presentation is talking about. But ultimately, we're going to be identifying classes of medications, mastering each of those classes, comparing asthma medications, and then, as always, we're going to do some dosage calculation because that will be on every assessment. So let's get into an introduction of the respiratory system. So before we even start talking about any medication names, let's just remember what the respiratory system is actually doing. Because every side effect or contraindication of these medications can trace back to one of these jobs of the respiratory system. So at the most basic level, the lungs are doing a gas exchange. Oxygen in, carbon dioxide out, down at the alveolar capillary membrane. But notice the slide also lists airway defense and acid-base regulation. So those aren't just afterthoughts. A drug that dries out mucus too aggressively, for instance, is interfering with airway defense, not just comfort. So a drug that affects breathing rate is touching acid-base regulation, not just oxygenation. So here's the organizing idea I want you to actually take away, rather than the list of functions itself. So this system is split into upper tract and lower tract. And that split is going to basically organize the entire unit today. So the upper tract, your nose, your pharynx, and your larynx. So those warm, filter, and humidify air. And that's where allergies, like the cold and congestion, live. And then you have your lower tract, your trachea down through the alveoli. And this is where gas exchange and airflow happen. That's where asthma and COPD live. And so one more thing that's worth sitting with for just a second. Route matters enormously in this unit in a way it doesn't in other units. So the exact same drug class can behave completely differently depending on whether it's inhaled, sprayed in the nose, or swallowed as a pill. So keep asking, where is this drug actually going as we kind of move through this presentation? It'll explain a lot of the differences in the side effect profiles that you are going to see. So this slide is really just a map of the way this presentation is laid out. So let's use it rather than reading every just kind of like medication class listed. So notice the split lines up exactly with what we just talked about. Upper tract problems are mostly about irritation and secretions, so allergic rhinitis, sinusitis, the common cold. So these medications are the antihistamines, the decongestants, and the cough or mucus agents. And then the lower tract problems are mostly about airflow. So asthma, COPD, chronic bronchitis. So these medications are the bronchodilators, the anti-inflammatories, and a few newer medications. Now, when I say throughout the presentation, you will hear me say drugs, or I will say medications. Same thing, right? They're medications, they're drugs. The words are used interchangeably. So we're going to focus on lower tract first today, and then we will move to the upper tract, which is the reverse of how the slide lists them, but that's a little bit on purpose because the lower tract secretion is where the rescue versus control concept lives, and I want that concept fresh in your mind as we get through the unit. Okay, so this is going to be the non-infectious lower airflow disorder medications. So we will start with asthma and COPD. So those are your bronchodilators, your anti-inflammatories, and then other biologics. We will get into those. So the first class of medications are the beta-2 adrenergic agonists, and these are albuterol and salmeterol. And these medications basically have the same mechanism of action. So the beta-2 receptors sit on bronchial smooth muscle, and stimulating them raises a signaling molecule called CAMP inside the cell, which tells the smooth muscle to relax. So then relaxed smooth muscle means the airway is widened. And that's the whole mechanism for both of those medications. So here's where it gets clinically important, and it's the first example in the rescue versus control theme of these medications. So albuterol is a SABA. It's a short-acting beta agonist. And then salmeterol is a LABA. It's a long-acting beta agonist. So the short-acting, the albuterol, that works by like immediately opening up the airway. So those are the ones that you're going to use when your patient is having like an acute asthma attack. And so the LABAs are the long acting, and those are the maintenance medications. That's what's going to help keep the airway widened over time. Because it's long acting, it's slower acting to get to that therapeutic level and then maintain its job of keeping the airway widened. So what's important to know is that LABAs are never used alone, and they are never used for an acute asthma attack because the onset is too slow. So someone who's struggling to breathe right now, that medication is not going to act fast enough to widen the airway. So it's used as a maintenance medication, but it should also be used with like an inhaled corticosteroid. So one piece of patient education that's important to make sure you include is the early warning system. So if a patient tells you that they are using their rescue inhaler more than usual, that's not just an inconvenience. We don't want to brush over that. That's signaling that the disease is getting worse and their control regimen needs to be reassessed. So rising use of their rescue inhaler is a red flag. So the next section are the anticholinergics, the ipratropium and the tiotropium. And these work by blocking acetylcholine at the muscarinic receptor in the airway. So it's a contrast to the last slide with the beta 2 agonists. They actively relax the muscle by turning on the receptor signal. Anticholinergics work the opposite direction. So they block the signal that would otherwise cause bronchoconstriction and extra mucus. So clinically, these are maintenance drugs for COPD. And just like the LABAs, the long-acting beta agonists, these medications are not for acute rescue. The onset is too slow to help someone that's having an attack right now. Now, also with these medications, and it's with the formulation, it's with the way the medication is manufactured versus the mechanism of the medication. But in the formulary process, somehow soy and or peanuts are used to manufacture the medication or used somewhere within that manufacturing process. So we want to always pay attention to our patients' allergies and make sure that they are aware that these hold a soy or peanut allergy warning. And then, as we know with anticholinergics, they cause that drying up effect. So the side effects that the patients will see using these medications are dry mouth, blurred vision, and urinary retention. Those are your classic anticholinergic effects. You will see these same effects, though, that dry mouth, blurred vision, and urinary retention in a few slides when we get to the first generation antihistamines. It's sort of like the same receptor families being blocked, so it's got the same predictable pattern. But we will talk about that in a few slides when we get over to the antihistamines. So next up, we have the methylxanthines. So theophylline is a drug I want you to think of as like the old guard of asthma treatments. So it was a mainstay decades ago, and it's now a second line specifically because it has a narrow safety margin. But this medication inhibits an enzyme called phosphodiesterase, which raises CAMP. So notice that that's actually the same downstream signal as albuterol, just reached through a completely different route. So basically, different door, but to the same room. So here's the fact that I want to anchor for you. Theophyline's therapeutic range is 5 to 15 micrograms per milliliter. So that's an unusually tight window compared to most medications you'll learn throughout this semester. So too little and it doesn't work, but then too much and you can have seizures and dangerous heart rhythms. So that narrow margin is why routine blood level monitoring is not optional with patients on this medication regimen. It's the whole safety strategy for this medication. So here's a detail that makes for a great teaching conversation with your patient. So theophylline is chemically related to caffeine. They're in that same xanthine family. So caffeine doesn't just have an additive stimulant effect by coincidence. It's genuinely a chemical cousin competing for the same pathway. That's also why smoking matters so much here. So smoking actually speeds up how the liver clears this medication. So if a patient on theophylline quits smoking, their levels can rise sharply afterward. So the provider needs to know before that happens, not after toxicity symptoms start to show up. Corticosteroids are next, and corticosteroids are the anti-inflammatory workhorse of this entire section. And I want you to notice something structural about this slide before we even get into the details. So it's organized by route, not by drug name. Oral prednisone, nasal fluticasone, inhaled budesonide. Same basic anti-inflammatory mechanism, three different clinical roles depending on where it's delivered. So the mechanism in plain terms, these medications calm down the inflammatory response, reduce airway swelling, and cut down mucus production. But notice the phrase over time in the mechanism description. This is not a fast-acting medication. That's the single most important safety concern or safety concept for this slide. So corticosteroids at any route are never for acute bronchospasm rescue. They're treating the underlying inflammation that's driving the disease process, not the immediate muscle spasm. So they can't simply act fast enough to help someone who's struggling to breathe right now. So pair that with what we said about salmeterol a few slides back, the long-acting beta agonist, and now you're building a pattern. So several of our most important asthma control medications are, by design, too slow for an emergency. So the adverse effect I want to spend real time on is long-term oral use causing adrenal suppression. So here's why that matters clinically. So your adrenal glands normally make their own steroid hormone, cortisol. So give the body external steroids for long enough, and the adrenal gland essentially gets lazy. It scales back its own production because the external supply is covering the need. So then you stop the external steroid abruptly, and the adrenal glands can't ramp back up fast enough, and you can precipitate a genuine adrenal crisis. So that's exactly why oral steroids get tapered and never stopped cold turkey. The taper gives the adrenal glands time to wake back up and start producing the hormone again. Moving on to mast cell stabilizers. So cromolyn, the prototype medication, has a different job than the medications we've discussed so far. So it does not relax smooth muscle, and it's not really treating existing inflammation either. So this medication is purely preventative. So you want to think of mast cells as little grenades that are packed with histamine. They're ready to go off whenever they encounter an allergen or a trigger like exercise. So cromolyn stabilizes the membrane of that grenade so that it can't detonate in the first place. But, and this is the key limitation, it can only stabilize a mast cell before it's triggered. So once the histamine is already released, cromolyn will do nothing for you. That's why it has a zero role in like an attack. You can't use this medication in an attack that's already happening. So this medication does get taken on a fixed schedule, even if symptoms are not persisting. If the patient is symptom free, you still take this medication as scheduled. And you tell your patient that it will take several weeks before they notice a benefit of the medication. So giving up after 2 days is basically how this medication is intended to work. It's intended to build up. So they won't see any result within the first 2 days. For exercise-induced bronchospasm specifically, this medication does have to be given 10 to 15 minutes ahead of time, and that's locking down the mast cell before the trigger even happens, not reacting to the trigger after it happens. So next are the leukotriene modifiers. So the prototype montelukast blocks leukotriene receptors. So just a quick refresher, leukotrienes are inflammatory chemicals released during an allergic or asthmatic response to the cause of bronchoconstriction, swelling, and extra mucus. So if you block their response or if you block their receptor, you blunt that whole cascade. So it is a pill that's taken daily, typically in the evening. But this one, the adverse effect that I want you to pay close attention to, because it does carry the boxed warning, are the neuropsychiatric effects. So that includes mood changes and suicidal ideations. So this is a pill that looks completely benign on the surface, right? No needles, no big physical side effects. That's exactly why the mental health monitoring point is so easy to skip when we're educating these patients. So we always want to make it a habit to specifically ask about mood with this medication. The same way you would check, blood sugar with a steroid, with this medication, you're regularly assessing the mood. You're regularly asking the patient if they've noticed any changes in their mood. Specifically ask them, are you having suicidal ideations? So the monoclonal antibody class and the prototype medication is the omalizumab. And this is the newest and most targeted medication in this whole lower tract section. So the way that this medication works, it binds up circulating free IgE, and that's the antibody responsible for triggering allergic reactions. So it's essentially mopping it up out of the bloodstream before it can go and attach to a mast cell and set off the whole allergic cascade. So instead of stabilizing the mast cell like cromolyn does, this medication removes the trigger before the mast cell even gets involved. So this is reserved for moderate to severe persistent allergic asthma that isn't controlled by an inhaled corticosteroid. So it's kind of a step ladder, not a first line of choice. So here's the irony I want you to sit with for a second, because it's a great teaching point. This is a drug for allergic asthma that itself carries a boxed warning for anaphylaxis. So you're giving an injectable biologic to calm an allergic response, and the drug itself can trigger a severe allergic response. So that's exactly why patients are observed for 2 full hours after the first 3 doses, and why they need to carry their own EpiPen while they are on this medication therapy. So keep that in mind with this medication. For the first 3 doses that this medication is administered, the patient is closely monitored for 2 hours, because it's doing its job of preventing a severe allergic reaction. But the way the medication is designed, it can trigger a severe allergic reaction, that anaphylactic response. So we make sure we monitor the patient for 2 hours after those first 3 doses. And then even after those doses, you educate your patient to always carry their EpiPen with them while they are receiving this medication regimen. Next, we have the PDE4 inhibitor. So roflumilast is worth knowing mostly by contrast with everything else on this list, because it's easy to lump it in with bronchodilators. But that would be a mistake. So this medication inhibits the phosphodiesterase 4, which sounds similar to theophylane's mechanism, but notice the outcome described on the slide. So decreased inflammation associated with COPD, not bronchodilation. So this drug is not opening the airway directly at all. It's an anti-inflammatory, and it's specifically for severe COPD with chronic bronchitis, aimed at reducing exacerbations over time. So the adverse effect that genuinely surprises people with this medication is weight loss. So this isn't a drug that you'd be expected to affect appetite or metabolism. So it's worth actually weighing patients regularly rather than assuming it's a non-issue. And it's the same theme as Montelukast. So we watch for those psychiatric effects, including depression, and we screen proactively rather than waiting for the patient to bring it up. So it's not a medication that you would expect to affect appetite or metabolism. So we make sure we're weighing our patients and we're telling patients to monitor their weight and let us know if there's any weight loss that's happening with these patients. Also, we're paying attention to those psychiatric effects and we're proactively screening about changes in the mood. We're specifically asking them, are you having thoughts of self-harm? Are you having thoughts of harming someone else? Because, that can go along with mood changes as well. So moving over to neurotransmitter slash hormones, and the prototype medication here is epinephrine. Now, epinephrine is the odd one out for this entire slide. And I want you to notice why. So everything else in this section has been reasonably selective, hitting one receptor type or one pathway. But epinephrine hits everything, alpha, beta 1, and beta 2, all non-selectively. So think of it as the sledgehammer of the unit. Beta 2 stimulation gives you bronchodilation, same as albuterol. But alpha stimulation also gives you vasoconstriction, and beta 1 stimulation also speeds up and strengthens the heart. So that's not a side effect bundle you want for routine asthma control. So this is exactly why this medication is reserved for a true emergency, anaphylaxis or status asthmaticus when nothing else is working. So the most important patient education point isn't about the mechanism of the medication at all. It's about what happens after you use it. So you call 911 immediately after every dose, even if the symptoms improve. Because epinephrine wears off faster than an anaphylactic response can fully resolve itself. And a second wave of symptoms, it's called a biphasic reaction, can follow later, sometimes hours after. So feeling better right after the shot is not the same as being safe. So if your patient is at home and they are using epinephrine, or maybe they're in like a long-term care kind of facility and they're using epinephrine for an anaphylaxis response or status asthmaticus, outside of the hospital, the important thing to do is call 911 immediately after the dose is given, even if the symptoms improve. Of course, in the hospital setting, if we have to give epi for an anaphylaxis response or status asthmaticus, we are already, in that process of continuously monitoring this patient. All right, so we will switch tracks now and move over to the upper respiratory disorders. So now we're in the nose, the throat, and the cough reflex itself. So those are antihistamines, decongestants, antitussives, expectorants, and mucolytics. So we're no longer opening airways or calming chronic inflammation. We're now managing symptoms or irritations, allergies and secretions. This is a fundamentally more surface level, short-term kind of therapy compared to like chronic disease management we just discussed. So first generation antihistamines are first, and that prototype medication is diphenhydramine or Benadryl. So diphenhydramine works by blocking H1 histamine receptors, which is exactly what you'd expect from an antihistamine. But the detail that actually defines this drug clinically is right there in the mechanism. It crosses the blood-brain barrier. The blood-brain barrier. Say that 3 times fast. So that single fact explains almost all of the adverse effects within this profile. So cross into the brain and you get sedation, which is exactly why this drug doubles as an over-the-counter sleep aid and not just an allergy medication. So it also has significant anticholinergic activity, which remember back to the ipratropium a few slides ago. So it's the same family of side effects. So the dry mouth, the blurred vision, and the urinary retention. So they are different drug classes, but it's the same receptor family. So it's got that same predictable kind of pattern. So the teaching point I want to really land here involves older adults specifically. So this medication shows up on the Beers criteria, a list of medications considered higher risk in elderly patients. So in Brightspace, in the resources that are available for this module, you've got that Beers criteria list. So make sure you're paying attention to that because this medication does show up on that list. And largely because the sedation and anticholinergic burden significantly raises fall risk in someone whose balance and cognition may already be more fragile. So a drug that seems like a harmless allergy pill for a younger adult can be a genuine safety concern in the older adult. Okay, so then we have the second generation antihistamines. That's the cetirizine and the loratadine. And these are basically like the answer to the side effects from the first generation, the diphenhydramine. So they do the same job. They block the H1 receptor, but it's been engineered to specifically stay out of the brain. So it's minimizing that blood-brain barrier crossing. So because it doesn't get into the brain, it has less sedation, fewer anticholinergic effects. And I shouldn't say it stays out of the brain because it's been engineered to stay out of the brain. It does minimally cross that blood-brain barrier. So because it doesn't fully cross over, you don't have full-on sedation or full-on anticholinergic effects. So those effects are just minimal with the second generation antihistamines. And they're only taken once daily, where the first generation, the diphenhydramines, you will see those that you can take every 4 to 6 hours. But with the second generations, these are only once daily dosings. So that combination is exactly why these are now generally preferred over the first generation medications, especially in older adults where, diphenhydramine has that high risk profile. So cetirizine does cause a bit more drowsiness than loratadine, even though they are both second generation medications. So that is important to know. So it's not an all or nothing category. there is still a spectrum within. So next up are the sympathomimetics, or the decongestants. So phenylephrine is an alpha 1 adrenergic agonist, and it works by constricting the blood vessel in the nasal mucosa, which shrinks the swollen tissue that causes that stuffy nose feeling. So here is what is important to know about this medication. Because it does constantly show up like in real life with patients who buy this medication over the counter without even a second thought. And that's the rebound congestion. It's also called rhinitis medicamentosa. So if you use a decongestant nasal spray for too many days in a row, and then when it wears off, the blood vessels rebound and dilate even more than before. So that leaves the patient feeling more congested than when they even started taking the medication. And so, because they're now feeling more congested, that's going to tempt them to continue to try to use that medication, which is just causing this continuous rebound cycle. And it's at this point now counterintuitive. It's not even doing anything for the vasoconstriction that's happening. So that's exactly why the 3 consecutive day rule exists for this nasal spray specifically. And because this drug constricts blood vessels everywhere, not just in the nose, it can raise blood pressure and heart rate systemically too. So it is a real concern in patients who have hypertension or cardiac disease. And it's not just a nasal only medication the way it might feel for a patient who is reaching for it just casually. So moving on to antitussives, and these are codeine and dextromethorphan. So codeine and dextromethorphan both suppress the cough reflex at the medullary cough center. So they hit the same target, but they have a different chemical strategy. So codeine works through opioid receptors, and dextromethorphan does not, which is why it's available without the same controlled substance restrictions, although it does still carry its own abuse potential at high doses. So antitussives are only appropriate for a dry, non-productive cough. If a cough is productive, if your patient is bringing up secretions when they cough, suppressing that cough reflex actually works against the body's own airway defense. So essentially, you'd be trapping mucus that the body is trying to clear. And so, an important safety note, codeine specifically carries real respiratory depression risk and should be avoided in children under the age of 12. And combining either of these drugs with other central nervous system depressants, adds on to that depression risk. If codeine is already, because it's an opioid, it's already going to depress the respiratory center, giving something else that's going to cause that same depression is going to increase the risk of respiratory depression. And then dextromethorphan with an MAOI specifically raises serotonin syndrome risk. So this is definitely important to, when you're doing your medication reconciliation, to check before recommending this medication. So next are the expectorants, which is guaifenesin or Mucinex. And so guaifenesin is essentially the opposite of what an antitussive medication does. So antitussives suppress the cough, whereas guaifenesin thins mucus to specifically make coughing more productive, so that the secretions are actually able to come up and clear out. And that's why client education is so important here. This is explicitly not a cough suppressant, and giving it alongside an antitussive for the same cough would honestly work against the whole point that of thinning the secretions in the first place. What we also want to make sure that we are educating is to increase fluid intake, because that genuinely enhances how this medication work. Since thinner secretions generally come from better hydration, not just the medication alone. Also, a cough lasting beyond 1 week deserves provider evaluation. So we make sure that we educate our patients that if they are noticing this cough, productive or not, that's lasting longer than 7 days, that they should report that to their physician for further assessment. So next up are the mucolytics. And this is acetylcysteine. So this takes the expectorant idea just a step further. So guaifenesin increases the water content of secretions to thin them, whereas acetylcysteine actually breaks the chemical bonds, the disulfide bonds inside the mucus protein themselves, which physically loosens thick, sticky secretions. And this is used in conditions like COPD or cystic fibrosis. So if you notice, acetylcysteine is the same medication that's used as the antidote for acetaminophen overdose. So these are two completely unrelated clinical uses, but the same molecule. So one mechanism protects the liver during the overdose, and the other loosens mucus in the airway. So don't let a question about the Tylenol antidote throw you off if it's phrased in a respiratory unit context, because acetylcysteine is absolutely the antidote for acetaminophen or Tylenol overdose. So the practical teaching point that patients always ask about, yes, it genuinely smells like rotten eggs. That's the sulfur smell, and it is expected. It's not a sign that anything is wrong. Um, and because it can trigger bronchospasms, it's often given alongside a bronchodilator in patients with underlying asthma, um, as a protective pairing rather than just using it alone. Okay, so asthma medications, quick relief versus long-term control. So this slide is the payoff for everything we've built in this presentation. So let's actually use it that way rather than reading the two columns from top to bottom. So here's a way to think about it that I find sticks better than memorizing two separate lists. So rescue drugs are like a fire extinguisher. They work in minutes. They work on smooth muscle directly, and you reach for these when there's already a fire, when there's an acute attack. Control drugs are more like a sprinkler system that you install ahead of time. So they act over days to weeks. Mostly on the underlying inflammation, and their entire job is to prevent the fire from starting in the first place. Um, so look down that quick relief column. Albuterol, ipratropium, an oral steroid burst, epinephrine. So what do you notice here? Every one of those we already discussed, and I specifically flagged the speed of onset for each one of these. That wasn't a coincidence. I was building that list for you kind of slide by slide. And then the long-term control column, the salmeterol, the budesonide, Montelukast, cromolyn, theophylline, and the omalizumab. Every single one of those, I told you explicitly on its own slide, are not for an acute attack. So if you were tracking that phrase for all classes of these medications, you've already built this table in your head before even seeing it here on the screen. So one nuance worth calling out by name is salmeterol is control, but it's always paired with an inhaled corticosteroid. It's never just a medication that's being given on its own. So that's just worth remembering as a little rule on its own, like within a bigger rule. So this slide just, compares asthma medications, actions and adverse effects. So I'm not going to just, read this slide row by row, but just, point out a few things. So like fast bronchodilators are rescue. Anti-inflammatories and biologicals are control. Theophylline sits in sort of like an interesting middle spot. It is technically a control, but with that narrow therapeutic index, it does, have that tightrope, meaning it demands more monitoring than any of the others in the column. So the nursing focus line at the bottom is really the whole unit, just kind of distilled into one sentence. Rescue drugs act fast on smooth muscle. Control drugs target the underlying inflammation, and mismatching the two is a common, genuinely dangerous error. So if a patient tells you that they use their daily inhaler during an acute attack and felt no relief, that's not the medication failing. That's very possibly a rescue versus control mix-up, and it's worth investigating exactly that way. So let's shift into math for the rest of the unit. Do some dosage calculation because that always shows up on an assessment. It's going to continue to show up and it's going to be all over NCLEX. So we will jump right into that. So this slide just goes over the dosage calculation foundations. We are already familiar with the oral or tablet dosing, which is the desired over half times the quantity. But if you use dimensional analysis, that's okay too. Just pick one of those and just make sure you stick to that for your oral or tablet kind of dosing calculations. Weight-based dosing shows up a lot in this unit, specifically with like pediatric respiratory patients. So you think of like nebulized albuterol for a child. Those are dosed by their weight, not just like a flat adult dose. So the habit you want to build is always compare your calculated dose against a stated maximum. So a correct calculation that exceeds a safety ceiling is still a problem. So even if you did the calculation correctly and you came out with the correct answer, if it's greater than that safety maximum or if it exceeds that maximum, it is still an issue. And then IV infusion rates comes up here with like theophylline infusions. So remember that narrow therapeutic window that we discussed. So that's exactly why IV theophylline dosing has to be precise and why you convert a weight-based order into a total dose per hour before you even like get to the rate calculation. So let's work through these dosage calculation questions. So prednisone is ordered at 40 milligrams and you have 20 milligram score tablets on hand. So desired over have times the quantity. 40 divided by 20 times 1 gives you 2 tablets. And so you do your quick reasonableness check. So does 2 tablets or a 40 milligram total sound like a reasonable adult prednisone dose? Yes, it does. So make sure you're doing that kind of check, because even like a misplaced decimal means that this patient would receive, too much or too little medication. So the second example, it's weight-based. So albuterol nebulizer solution ordered at 0.15 milligrams per kilogram per dose with a 5 milligram maximum for a 20 kilogram child. So the first step is the total dose. 0.15 times 20 gives you 3 milligrams. So the second step, and don't skip this one, 3 milligrams under the stated 5 milligram max is 3 milligrams under the stated 5 milligram max. Yes, then the medication is safe to proceed. So the third step is to convert the volume using the 5 milligram per milliliter concentration on hand. So 3 divided by 5 gives you 0.6 milliliters. So notice that the extra step compared to the adult example. So with a weight-based pediatric order, you always check the max before you draw anything up, not after. So let's combine some skills and talk about IV rate infusion, the way that you would see it happen on the floor, the unit that you're working on. So theophylline is ordered IV at 0.4 milligrams per kilogram per hour for a 70 kilogram patient with 400 milligrams and 250 milliliters of D5W on hand. So first, the dose per hour. So you have 0.4 times 70 gives you 28 milligrams per hour. Second, the concentration of the bag. So 400 milligrams divided by 250 milliliters gives you 1.6 milligrams per milliliter. And then third, the rate. So 28 divided by 1.6 gives you 17.5 milliliters per hour on the pump. Okay, so now it's your turn to work this next question on your own. So pause it here and genuinely pause it here, work through it, and then press play and see if you worked through it the correct way and came up with the correct answer. So guaifenesin oral liquid is ordered at 300 milligrams every 4 hours, and you have 100 milligrams per 5 milliliters on hand. How many milliliters per dose? So here's the answer. 300 divided by 100 times 5 milliliters gives you 15 milliliters per dose. Did you get that? So these are your key takeaways, and I'm not going to read them bullet point by bullet point, but here's just a few things that stick out. So nearly every respiratory medication does one of 3 things. It widens the airway, it calms inflammation or an immune overreaction, or it manages secretions and cough. So sort any new medication into one of those 3 buckets, and you will already understand the role of that medication. So 2, rescue versus control is the single most important safety distinction in this entire presentation. Fast-acting smooth muscle drugs treat the emergency in front of you. Slower anti-inflammatory drugs prevent the next one. And mixing them up is genuinely dangerous. It is a common error, but it is dangerous. 3, corticosteroids and biologics are treating the underlying disease process, never the acute attack. That phase should feel like a drum beat by now. Because it's been repeated several times, every control drug we've covered. Number 4, the narrow therapeutic index drugs like theophylline and boxed warning drugs like montelukast and the omalizumab. Those need real active monitoring, not just a mention to the physician in passing. And then client education. So inhalers. So with inhalers, they should be rinsing their mouth after any inhaled steroid. Sorry. And then recognizing rebound congestion and knowing exactly when to seek emergency care. And then lastly, confident oral weight-based and IV rate calculation is a prerequisite for administering any of these medications safely, especially with pediatric dosing and narrow margin drugs like theophylline.